The contents of this video are for educational purposes only and are not intended to diagnose or treat medical conditions. You are responsible for your own clinical judgment. Presented by this episode and no relevant financial disclosures.
Hello, Dylan Valentine here with your FNP Mastermind community. We're going to be talking about hypothyroidism today. This is something you will definitely be seeing and dealing with in your clinical rotations, and something you will see as a family nurse practitioner quite commonly, occurring about 1 to 2% of the time in general population, and between 4 and 10% of the time, you will see subclinical hypothyroidism, which will define that condition later as well. So getting into the normal physiology of the thyroid function all begins in the hypothalamus. The hypothalamus will secrete a hormone called TRH, which stimulates the pituitary to secrete TSH, which I'm sure you've heard of before. This TSH will stimulate the thyroid gland to secrete T4, which is then converted to T3 in the liver and muscle tissues in the body. So the pathophysiology, where things go wrong with this process, can be divided into a few different types. Primary and central, or secondary and tertiary, is what central consists of. So the primary hypothyroidism affects the thyroid gland itself and its ability to release T3. So the types of primary hypothyroidism include Hashimoto's, which is known as the autoimmune thyroiditis, radiation or surgery to the area that impairs the thyroid's ability to secrete T3, or iodine deficiency, which you are not likely to see here if you're practicing in the USA. We don't have that problem very much here. Central hypothyroidism, as I said, is divided into secondary and tertiary hypothyroid. So secondary meaning one step away up the chain of command here in the pituitary thyroid axis. The pituitary dysfunction, most often tumors, sometimes Sheehan syndrome, which is necrosis of the pituitary, or drug-induced, such as amiodarone or lithium. Tertiary is one more step back in the process, so that's hypothalamic dysfunction. Moving on, let's discuss the symptoms and the diagnosis of hypothyroidism. So symptoms are going to include anything that you would imagine with metabolic slowing. So think Eeyore, slow, cold, hair loss. Common symptoms are going to include weight gain, cold intolerance, fatigue, depression. Other ones would be diastolic hypertension, dry skin, constipation, and in women, menstrual irregularities. Less common symptoms that you still should remember include bradycardia, cognitive declines, anemia, coarse hair, and slowed relaxation of the deep tendon reflexes. I will say when you're working somebody up for cognitive issues or dementia in old age, you will need to include this hypothyroid on your differential list and perhaps obtain a TSH, which is the primary lab to start the diagnosis of this issue. So you'll need to order a TSH anytime it is suspected. TSH norm range is going to be a little different from lab to lab and organization to organization. 0.4 to 4.5 will be your typical range. If the TSH is elevated, it is important to repeat that TSH and tack on a T4. When you get that repeat lab with the TSH and the T4, if the TSH is persistently elevated and the T4 is depressed or decreased, you can stamp that chart with hypothyroidism and start discussing treatment with the patient. Now, if you have that TSH still elevated, but the T4 is normal, that is what we call subclinical hypothyroid. That's an important label because treatment of this problem varies depending on the lab values and whether or not this is overt hypothyroid with a suppressed T4 or subclinical hypothyroid with a normal T4 and persistently elevated TSH. In those situations, you are going to want to check or add on a TPO antibody or thyroperoxidase antibody. This is a finding in the most common form of hypothyroid, Hashimoto's or autoimmune thyroiditis. That is the antibody that starts the problem with attacking your own thyroid. So this can be a predictor for progression to overt hypothyroid in patients who are subclinical. That is the value in checking that TPO antibody. You've heard of the T3. That is what is T4 is converted into in the liver and muscle tissue in the body. T3 has a very limited diagnostic value when working this problem up. It's fluctuates quite a bit, can be transiently low during illnesses, and can be misleadingly normal due to overstimulation of the remaining thyroid tissue by TSH. So not a great test to be ordering. There are more complicated issues that can involve value with the TSH being checked, but as for right now, all you need to worry about is that TSH and the T4. Let's talk about the treatment of hypothyroid. And for that, I brought my wife Emily to discuss the medications and some of the implications you'll need to remember in clinicals. So, first, we need to discuss who to treat. Which patients are the important ones to start treating? Obviously, those with confirmed hypothyroidism, which is elevated TSH with a low T4, will need treatment initiated. Then there's those with subclinical hypothyroidism. Again, that's those with a high TSH and a normal T4 will need to be treated under certain circumstances. That would include symptoms of hypothyroid or a TSH over 10, regardless of the presence of symptoms of hypothyroid. So, what is our standard medication to use for treating hypothyroid?
Yeah, the guideline recommended medication is called levothyroxine, and it's a synthetic version of T4. Um, if you spent any time in a pharmacy or looked at patients' med lists, there are many other products, but the guidelines
Mm,
don't recommend them for a variety of reasons that we won't go into here. So, for a standard dose for somebody with confirmed hypothyroid, the target dose is 1.6 micrograms per kilogram per day. So, this is the dose you want to target. Some people are started at this dose. Other populations, we start lower, and I'll go into more of that in a moment. But to give you some context, in the pharmacy world, we consider an average patient to be 70 kilograms. So it's probably around 150 pounds.
yeah.
Um, so a dose of 1.6 micrograms per kilogram per day would be 112 micrograms. Patients might have other calculated doses, but you round to the nearest dosing form that is available. So, some special populations that get a different starting dose are people who are high risk for developing hyperthyroidism and populations that we don't want to do that in. Those would be the elderly and patients with cardiovascular disease. So, for patients over 60 years old without cardiovascular disease, it is recommended to start at doses between 25 and 50 micrograms daily. And then for patients with CAD, cardiovascular disease, the starting dose is 12.5 to 50 micrograms daily. And we'll go into more why it's important to start low later in our discussion.
So it sounds like the more fragile the patient or more elderly, you just want to start a little more conservatively.
Sure. And I mean, since levothyroxine is synthetic T4, we can push those patients into
Mm,
hyperthyroidism. And those are patients who we don't want to do that
yeah,
to.
important to individualize care for that reason. So let's get into the monitoring after you've initiated treatment and titration or changing of the dose of this medication. So once you started the initial dose of the medication, you're going to want to recheck that TSH in 6 weeks after initiation. No sooner than that, or the TSH levels may not have kind of leveled out and they won't give you a true idea of what's going on with the dose you started on. So if you recheck that TSH after 6 weeks, a number of things could happen. TSH may come back completely normal, and hopefully the patient is reporting any symptoms they were having are resolved. Hey, congrats, you can maintain that current dose, check that TSH annually, or repeat that TSH on the onset of any new symptoms that may mimic hyper or hypothyroidism, or if the patient is a female and becomes pregnant, or with the initiation of other medications, as that may interfere with the absorption of the levothyroxine. If the TSH at that 6 week recheck comes back between 4 and 10, so you're still over, but maybe improved somewhat, increase by a more modest dose of maybe 12 and a half to 25 micrograms per day. TSH returns back between 10 and 20. Let's increase by a little more aggressive, 25 to 50 micrograms per day. Now, let's say the TSH returns 20 or greater. This is, you're going to be in the same boat as you were when you first diagnosed them. You're going to want to add that T4 back on again to help guide your dosing because the increase is maybe 50 micrograms or greater. At that point, you may also want to discuss this with a colleague or maybe discuss with endocrinology or refer them to endocrinology. If the TSH happens to come back low, that means you've given them too high of a dose and you're going to need to reduce that dose a little bit. So maybe a modest reduction in 12 as between 12 and 25 micrograms per day, and then recheck again in 6 to 8 weeks. Anytime you make a titration, you need to recheck that TSH again in 6 to 8 weeks to see what the results are. And of course, question the patient on their symptoms. Always 100% of the time with this medication specifically, check their adherence and how they're taking the medication, as that can have a lot of bearing on absorption and how the medication works in their body. So let's move on to the treatment of subclinical hypothyroid. Reminder, this is when the TSH is elevated and the T4 has remained normal. If the TSH is over 10, with or without symptoms, you'll need to start treatment. If the TSH is between 4 and 10, so elevated, but yet under 10, and they have symptoms of hypothyroid, that is another reason to begin treatment. And as we discussed earlier, checking those TPO antibodies for thyroperoxidase antibodies to assess for autoimmune thyroiditis, if those are elevated, that's another reason to consider starting treatment. If the TSH in subclinical is between 4 and 10, TSH is normal, no symptoms, you don't need to treat. Another reason to treat is if there is subclinical hypothyroidism present and the individual is struggling with infertility. That is also a reason to perhaps begin treatment, as that can make a world of a difference in their attempts at fertility. So the treatment regimens for
Yeah, it's gonna be very similar
yeah,
similar principles to treating, hypothyroidism, in healthy individuals without any risk factors. They're gonna start at a slightly lower dose than that 1.6 micrograms per kilogram per day that we discussed earlier. Some people, could even, you could even use your clinical judgment to elect to start at a dose as low as 25 to 50 micrograms. But again, in those patients with risk factors, the elderly, those with cardiovascular disease, it is recommended to start at those lower doses of 25 to 50 micrograms daily.
and the reason we start for subclinical hypothyroidism when they don't have overt hypothyroidism quite yet is because they may very well progress to overt hypothyroidism, and you want to kind of curtail those symptoms while that process happens. Otherwise, you'll see things like weight gain, higher risk for diabetes. Nobody wants to feel as somebody with hypothyroidism feels. So that's why it's important to treat even subclinical hypothyroidism when appropriate, when those criteria are met. You will use the same monitoring criteria while you're treating hypothyroidism as you would use for overt hypothyroidism. So if you are not treating because they don't have symptoms, you'll need to recheck in 6 months. And if they're stable, again annually and every year thereafter, as well as anytime they call and report symptoms. So the treatment considerations are very important in these groups we've discussed due to the increased risks of developing cardiovascular disease and other metabolic disorders. So that's that in a nutshell, how you decide who to treat and how to start the medication at which dose. So now that we've covered the diagnosis and treatment of hypothyroidism, let's get into some clinical pearls that'll help you along your way in clinicals and clinical practice and boards for the treatment of hypothyroidism. So, how would you counsel patients on levothyroxine and its side effects?
So, the side effects of levothyroxine, as we talked about, levothyroxine is synthetic T4. So, the side effects of having too much is hyperthyroidism. So, you can counsel patients to watch for signs of hyperthyroidism. Um, and this kind of calls back to why we start with lower doses in high risk populations like the elderly and people with cardiovascular disease, because what is one of the risks of hyperthyroidism?
Heart disease, heart problems, arrhythmias, myocardial infarction, hypertension. So, yeah, it's a good point.
So, Dylan, as a clinician, do you screen everyone for hypothyroidism, or are there special populations that you would be more likely to screen?
That's a great question. We talked about diagnosing and using that TSH test for diagnosing based on the symptoms. What about screening? So the guidelines vary so much from guideline to guideline. Basically, you need to use your clinical judgment. I've worked in a few different practices, and some include that as a group on their annual screenings. Some do not. So, your clinical judgment and individualized shared decision making with the patient will dictate whether or not you'll get the TSH on a screening basis. And of course, if you're getting that on a screening basis, we're not looking for overt hypothyroidism because you're not chasing symptoms down. You'd be essentially finding subclinical hypothyroid. Uh, Obviously, you will check on anybody with symptoms. You consider asymptomatic. You can consider asymptomatic screening in those that are any of the combination of being over 50, female, any other endocrine or autoimmune diseases, or cardiovascular disease. So that's in a nutshell. There's not a great straightforward answer to screening, but you can use your clinical judgment. So I want to know more about the levothyroxine, the proper dosing and administration. How should we counsel patients? Because it's so important with this medication.
Yeah, if you've spent any time in a hospital giving patients levothyroxine, you have thought about this before. But levothyroxine so medications, when you take a medication orally, you take it and it goes to your gut, and it's possible that it can pass right through your gut without being absorbed. And
Hmm.
levothyroxine is one of those medications that need a very specific environment to be absorbed. So we recommend taking it 1 hour before the first meal or 2 hours after the last meal. Also, it is recommended to separate from other medications by an hour. And if it is a calcium containing supplement, for example, Tums or an antacid, there's a recommendation of um, 3 to 4 hour gap before and after, just to make sure they're not interacting in the gut and the levothyroxine can be properly absorbed. But kind of a more recent conversation is that taking the levothyroxine is always better than not taking it under perfect circumstances. And it's been found that sometimes patients are given these instructions, and then if they can't take it right away, then they just skip it. But if they would take it even with a meal, they're going to get more than just skipping it. So, this is something you should always
Hmm.
think about when talking to a patient and just how this messaging will hit them. Um, Another pharmacy point we wanted to bring up was there are medications that can affect T4 in a
Hmm.
patient. Some of those medications, I'm not going to go into detail, are a arrhythmia medication called amiodarone, a medication called lithium, steroids, a supplement called biotin. Just be aware that all of these can either affect the T4 or labs. So if a patient is initiated on one of these medications by another provider, you should follow up and recheck.
Hmm.
Would
Ask
you
the
agree
patient.
with that?
Yeah, like we discussed earlier, assessing adherence and how they're taking the medication is essentially important at all visits that you discussed their hypothyroidism at. Especially if you get an unexpectedly abnormal TSH, they don't have symptoms, they've been on their levothyroxine for months or years. Man, maybe they started a skin, hair, and nail supplement containing biotin, and that'll change that TSH reading artificially. So that's why it's very important. So What about the different formulations? I know that there's a lot of manufacturers. We hear a lot about staying on the same one, brand or
Yeah,
generic.
this is another interesting thing with levothyroxine. With other medications, we consider the generics the same as the brand bioequivalent, and we consider all the generics bioequivalent with each other. But within levothyroxine, they have found that different manufacturers can have a different effect on people's labs.
Or
They're
is it the maybe absorbability too? It says,
Sure,
yeah.
yeah. So it is recommended that the patients stick with the same manufacturer of that generic. It's possible it won't affect them if they change the manufacturer, but you always have the option to recheck that T4
Mhm.
4 weeks after the change.
Then there's poor compliance. Just
Mm,
those that won't remember to take it. They just have varying routines. Something that I've heard and I've read literature on. Haven't had this happen in my own practice, but dosing your entire week on one day. Now, this is something that I haven't seen happen, but there are studies and literature to support if somebody cannot take this every day, you can take the weekly total dose. So their daily dose times seven, take it on one day. If it's a Saturday or a Sunday, a day that they will remember to take it every week, that may improve compliance, and it is better than missing so many of the doses.
right. And I'll just, yeah, make a point on this. Like, this isn't true of every medication, but the
Mhm.
unique thing about levothyroxine is it has a very long half-life, which provides this option for it.
Right. So that brings us to the end of our talk on hypothyroidism, the crash course on getting you ready to start seeing this problem and discussing with your preceptors. So let's go over a couple key facts, things that you absolutely need to remember. Number one, the symptoms of hypothyroidism. So anything slowing, weight gain, fatigue, cold intolerance, constipation. Those are your big ones. The target dose of levothyroxine being 1.6 micrograms per kilogram of the patient per day, and the hypothyroid diagnosis confirmed by the elevated TSH and a low T4. Those are your big key facts. So let's do a couple practice questions to close us out here today. I'll let Emily kind of play the role of student here to try to answer these. So, your 68-year-old male patient presents to your office with a known history of hypothyroidism and hypertension. He is presenting for his routine scheduled blood pressure medication check, but brings up that he's felt sluggish in the past month. You also note a 9-pound weight gain since his last visit 6 months ago. His levothyroxine dose is currently 125 micrograms daily. What is your next action? A. Check a T4. B. Further question regarding how he is taking the medication and if he misses any doses. C. Increase that levothyroxine dose by 25 micrograms per day. D. Check the TSH. Or E. No action. What do you see at first glance there?
So I think the A, check T4 looks interesting to me, but as you keep reading the questions, I feel that checking the TSH um, could be the way to go based on your presentation.
That's a very good answer to look at because checking the TSH would provide you a lot of clinical insight as to what's going on in this patient's body. But if we read the question carefully, what is your next action? So while checking the TSH is a good
Mm,
action, so if we read these answers again, and this is important while taking board questions, while Emily had a great answer with checking the TSH, it's going to provide you a lot of insight. B, further question regarding how he is taking the medication and if he misses doses. You know he's on more medications, right? He has hypertension, the question states. Maybe he's taking these medications together.
mm.
Maybe he's missing doses because he didn't wake up early enough to take it before his hypertension medication. But when you really read these questions, take all the words into consideration. And when the story was given and then the question was asked, what is your next action? The next action is to question him. Checking a TSH is certainly on the table too. I would probably do it as a clinician as well. Uh, So increasing the dose, not your next action. You want to get more information first. So, all right, next question. The gentleman in the previous question states he is taking his prescribed levothyroxine daily in the morning, right when he gets up, does not eat or take any other medications or supplements for at least an hour after his levothyroxine dose. His wife corroborates this story. You decide to check his TSH and it is elevated at 6.2. What is your next action? A. Check a T4. B. Keep the same dose, follow up in 6 weeks. C. Increase that levothyroxine dose by 25 micrograms per day. D. Check a T3. E. Get a thyroid ultrasound. What do you see here at first glance?
So I am attracted to C, increase the dose by 25 micrograms, but I am known to be tricked.
So again, what is your next actions? We have to think of what is the very next thing we're going to do. Reviewing the story, this man is claiming he takes everything as prescribed without missing doses. And perhaps the most important part is his wife corroborates the story, meaning probably true. You already checked the TSH and it's elevated, so you've done a few steps already. I think the answer you're attracted to is probably the best answer here. Increasing that dose by 25 mics per day. You've already been able to rule out by the question he's doing everything as he should be, taking the medication appropriately. You've checked the TSH, it is elevated. And since this question references the man in the previous question, he said he felt sluggish. So he has symptoms as well. So it is appropriate to increase that dose by 25 mics a day. And then an add-on question, what are we going to do after we dismiss him from our office?
We're going to schedule a follow-up lab.
How many weeks?
4?
6.
6.
6 weeks.
6.
6 weeks rechecking that TSH just to make sure that things are going as planned, and you're going to want to ask him how his symptoms are as well. So thank you for joining us on this hypothyroidism talk. We hope that this gives you some confidence to proceed in starting your clinicals, to be able to interact with your preceptors and see patients with this problem. So we look forward to seeing you for more clinical content. Thank you.